Oops.
Yes, and we're live. Okay. Welcome everyone to this new episode of the TOT Doctors Roundtable. Oh, there's a lot of noise here on the screen.
Dun, 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 huh?
Yeah.
Thought we're gonna have a dance off.
If you haven't already, please subscribe by hitting the red button and the notification bell so you won't miss anything. And today we have on our panel, as you can see, Dr. Eric Serrano. Welcome, Eric.
Welcome, Steven. Thank you.
And Danny Bossa as a co-host together with me to ask a bunch of questions that we already had on our Facebook group. If you haven't already, please join our Facebook group TRT and Hormone Optimization Therapy HOT that you surely must be interested in if you are watching this interview. The link you will find under this video. So we have a whole bunch of questions for Eric today, and you can still ask in the chat box extra questions if you would want to during this session. Okay, so maybe Danny, start with the first question.
So Eric, we got a whole bunch of people that are very anxious to throw questions your way and get your wisdom and all-knowing knowledge here. So we got a lot of questions for you. So we're gonna throw them kind of at you, and one after the next. You can give us kind of a brief answer, because there's a whole bunch, and there's probably gonna be more that's gonna come in through the chat box. So the first one. The guy's asking about the production of idiopathic hyperprolactinemia following a 4-month period of being denied testosterone you've been on for 20 years, and how you'd go about reversing its effects. No joy, zero libido, muscle loss, and weight gain when you've been back on the testosterone, but the prolactin persists, no tumor. So this is a guy who was on testosterone for 20 years. He had to move. The doctors in his area says, no, we have to take you off the testosterone. We got to get your baseline levels. His levels crashed after 20 years. The guy had sent me pics. He was in really, really good shape, super strong. He showed me pics of the aftermath just a few months later. He's obese. He says, my diet is the same, training is the same. He says, I'm just gaining weight. My prolactin is completely out of control. Now I'm back on some TRT, but my prolactin levels still remain high. He's not taking an AI. They checked for prolactinemia tumor and found none. And the doctors are stumped. How come he's got this high prolactin? So what do you have to offer?
Okay, I got a question for you, Danny. Do we have any levels on him? Do you know what the prolactin levels were?
They were, I don't remember the number offhand, and I could probably find it quickly.
No, no need to. On this guy,
they were way up.
Well, you also said that he had a negative MRI of the head, correct?
Correct.
Okay, so this is the one that you are looking for. When you look at horses, then you have to look for a zebra, number one. So this one has very high prolactin levels. So you need to look for an outside access to this guy. Number one is there are some tumors outside of the brain, like lung tumors that can produce hormone, like ADH producing hormones on the lungs. So this guy, I will do something a little deeper than that. I'm assuming that they check his thyroid. Okay, they check ADH on this guy, all those things. And we're assuming a lot of things here. So, okay, let's suppose that everything turns out to be normal, okay? Everything in his blood tests, we do CAT scans of the upper body, and we look for exogenous sources. Then I will use something called bromocriptine, in which it will lower his levels very drastically, actually. Now, with a level that high, I expect physical findings, like, for example, lactating almost, if they're that high. Like, it will produce some type of milking discharge from his nipples, which he doesn't complain about, which is very rare. So this is a very, very cool case. This is a case that I would love to have for myself. But on this time and age, I will check a TSH. I will also look for, I will get an X-ray or a CAT scan of his upper body. I will also do an adrenal study. I will get a urine, 24-hour urine of all the hormones to make sure there's nothing else going on. But I'm assuming that they check everything, including oxytocin, TSH, everything else. He
Eric,
can have it.
the concern here is that for 20 years he was on TRT, never had an issue. It's when he was forced to stop, that's when everything happened, right?
I have seen in 2 cases in my practice, I have seen some people that do have increased prolactin levels when they were using HCG. I've seen it once, and I also have seen, and that's because I seen activated something. I don't have the answer for that. And I have seen another guy in which he went in and out testosterone, but on himself, and his prolactin levels were high. But they eventually stopped. I put on bromocriptine, I follow him, and after 7 months, he went back down to normal. And I went enough of the bromocriptine, and he was back to normal. There's much more here because this guy must be very obese. That's the first thing that I want. How obese is he? Do you know?
He got big. I saw the before and after that are literally separated by a few months, and it's astonishing the difference that cutting out that TRT did.
You see, there's much more on that. So we need to find out why he's having levels that high, and the only way to do that is like looking for other things, and even like I said, including a CAT scan, make sure that he doesn't have a tumor that is producing prolactin. Now,
there was none found.
Okay, so this might be related to the testosterone treatment, believe it or not. I don't know how it's correlated. So I might have to go look myself this answer. But on people that go on and off, maybe the pituitary gland says, hey, this is out of control and just going to make prolactin, because prolactin actually lowers your testosterone levels anyway. So by me putting you testosterone, I do something. Now, how long has it been on testosterone now? Do you know? How many months?
Again, I'd have to look for that exact post. I could probably
tell him Danny, if he has been on testosterone for more than 3 months, then I look for another answer. It's not that simple.
My guess with him was they did not give him. He was taking 200 milligrams a week for about 20 years.
Okay, but then they stopped it.
Everything went bad, and then when they finally put him back on, they think they only gave him about 100 milligrams a week. And he was just getting fatter and fatter. His prolactin is 91 NGDL.
Okay. What's the normal levels for him?
It's 73 points above where it should be, according to the clinical range.
Okay. You see, when you say he was doing good and then everything went bad, what do he mean by that? They stopped
they stopped all TRT.
So what particular?
Because they were just morons. They just didn't. They had no grasp on TRT, whatever. It says, no, we're going to follow you, but you're going to get off this testosterone stuff. We want to measure your baselines, and we're going to see how you react, and blah, blah, blah. And everything just went horribly wrong. And it just delayed.
And now he's in testosterone 100 milligrams?
Yes.
How much does he weigh? About how much do you think he weighs?
According to that picture right now, probably 250 at least.
Okay, so tell him to increase his testosterone levels to 250 milligrams per week, wait 4 weeks, and recheck prolactin levels.
To see if the higher levels of test lower the prolactin.
And see what happens to his prolactin levels.
And how does the bromocriptine compare to cabergoline? Is it the same?
They're about the same. They're about the same.
Okay.
Bromocriptine is oral, easy to take, once a day or twice a day. Also lowers your sugars, and it will help you lose weight. That's what I will use that.
Okay.
Okay.
Very good. Stephen.
Okay. Yes, Eric, next question was, what's your opinion on fast release versus slow release thyroid medication? What do you prefer to give?
I use slow release T3 in my office. Okay. I also use Thyroid, which I don't know what you guys call it there. What is dissolved in your mouth? Do you guys have that or not?
Tyrosine is not not an amino acid.
No, Thyroid is a prescription thyroid that you put on your tongue and dissolve very quickly. So it's very fast acting. So I use everything in my office. It depends. This is one of those that depends on your client or patient. What are you looking for? Is this person responding to your oral treatment? There's people that will not absorb the thyroid due to gastrointestinal conditions. For example, people have Crohn's or ulcerative colitis, and initially they do not absorb the thyroid. So I might use Thyroid T4, which is only T4. And I said, okay, I'm going to give it to you. I might use T3 sublingual because they have issues. But most of the time, sustained release, I will use T3 absolutely. And I will combine it with T4. I never use T3 by itself. I will use T4 and T3. And let me explain why I do that. If you have a borderline hypothyroid, right, Stephen, and I give you T3 only, and your TSH was slightly elevated because he was noticing that, hey, my thyroid is not normal. Now, when I do that, yes, I lower my TSH and you initially feel better, but you also stop the conversion from T4 to T3. So you stop the iodinized 1 and 2 from doing the work because now I'm giving you too much to T3. So be aware of that. Always start with the lowest dose unless you want to have some kind of emergency result in this patient is really bad or very depressed or a pregnant that is postpartum depression, then I do that. But otherwise, I will use any of them. It's just depending on the condition. One thing that I do tell you, Stephen, on Synthroid or any of the thyroids, I never use the high dosage or lower dosage on T4. I only use the 50 micrograms. You know why, Stephen? It's the only one with no dyes.
Nope.
The other ones have blue dye, red dye, because they have different colors. And some patients are allergic, like they do great on 50, and they can take 150. If I give them the 150 microgram tablet, which is pink, I think, they have issues. So I just give them 350s, and they do better without the side effects of the dye.
Oh,
Okay.
So be aware of that. I hope that answers that question.
That depends on the brands, probably.
That depends. Yes. Also, here it will also depend on your insurance. Are they going to cover that particular medication? And slow release T3, they do never cover it. Tyrosint, they fast dissolve, they never cover it. So that's kind of tough here. So some people can't afford it, some people don't want it. So I got to play also with the insurance company.
Okay, Danny.
okay. Next question. Dealing with high levels of reverse T3 and thyroid supplementation. If you've got high levels of reverse T3.
Okay. Do you guys, okay, let me give you a little bit of physiology here. Reverse T3 is activated by the iodinized 3. There's 1, 2, and 3. Okay, reverse T3 is inactive, supposedly, okay, you read the research, is the inactive form of reverse T3. I didn't believe too much on reverse T3 until when I was in charge of the ICU, I started checking reverse T3. The higher the stress, the higher the complication, the reverse T3 was also high. And I think it's a way of the body protecting itself against, high cortisol levels, against diseases. We do want to be burning energy, but what we need it for. So I use reverse T3 actually as a stress marker. So in a person that has high reverse T3, I say, okay, why is your reverse T3 high? Now, this can be to stress, it can be to low selenium levels, it can be to autoimmune disease. So I have to find out the reason why. Sometimes might be physical abuse between the husband and the wife. Like I have found out sometimes, I do exam on a woman that says, we're doing great, blah, blah, blah. Reverse T3 are 50 or 40. I'm like, wait a second. I talk to the woman alone, and she told me, my husband abuses me, but nobody knows that. And things like that. So it can be an indicator of high levels of stress. Now, before I treat reverse T3, which I would treat it differently, Stephen, I can either add T3, to make sure that I have overabundance of T3, or I can say I need to control your stress level first, or what is causing the stress. Can be hypercholesterolemia, can be, rheumatoid arthritis, can be Crohn's, some cells affected. I need to find out. I need to control that, and I will use reverse T3 as a follow-up. Now, there are some laboratories or some IF physicians that use T3 as a ratio, and they tell you that it has to be 12, 6 to 1. Some people say, other people say 12 to 1, other people say 22 to 1 ratio from reverse T3 to T3 to reverse T3, excuse me. In my practice, I use the ratio when I'm like borderline. I'm thinking I use 17 to 18. That's my free T3, excuse me, to reverse T3. And I do that, and then I say, okay, maybe I'm borderline. I'm going to do I work on your stress? Do I add T3? Depends what I'm doing. Now, if I am following a reverse T3, Danny, I'm also checking vitamin A levels. You're going to ask me, what the hell does vitamin A levels have to do with anything? Okay, for the thyroid to work, I have a mnemonic called ACER, amount, conversion, okay, expression, and ratios. And I can have 10 pounds of thyroid in my body, but if the receptor doesn't work, so I have all these keys, my receptor doesn't, or my key log doesn't work, my thyroid is not going to work as well. So vitamin A is necessary because the receptor for thyroid is retinoic acid thyroid dependent. So you require vitamin A. Now, most people are going to say, oh, I take beta carotene. Well, beta carotene, it's funny, Stephen, because this adds another component to it. Beta carotene is the vitamin A for the vegetarian, but to change beta carotene to the active form of vitamin A, you require zinc, which actually is required also for making thyroid. So if you're taking a lot of beta carotene, and that's why you might see in some vegetarians very low levels of thyroid or very, very high levels, because either they're using the zinc to convert beta carotene to vitamin A, or they're doing something that is not correct. And that's what I look forward to. So it depends there, but that will give you a small answer to what I look for. I'm looking at reverse T3.
Okay, that's clear. Next question, Eric, about supplementing progesterone regarding fertility and why you should or shouldn't.
If you are we talking about a man or a woman here?
I guess a man.
Okay. Man, oof, Neil is going to kill me for this answer. Yes, I do. Okay.
For men?
For men, yes. Oh my goodness. I'm meeting with Neil in October, so this is going to be interesting. I use it because for two reasons. I have found out that on men with severe anxiety, I don't like to use Xanax or Klonopin or benzodiazepines in my practice. And I added progesterone based on studies done in traumatic brain injuries that have come recently out saying that progesterone, and actually there's conflicting. There's research saying that it works. There's research saying that it doesn't work. But I have found out that in men that I put on progesterone, hey, I need less Xanax. I also need to drink less. So those are little findings here and there that I said, whoa, hold on a second. You know, this is kind of crazy. Let me go up a little bit. So yes, I will use progesterone in men with traumatic brain injuries, with severe anxiety, have used it, okay? So those are my moments on time. Our fertility specifically, not for men, but for women. Now on fertility, I gotta look at two things. I'm a sperm producer or I'm not a sperm producer. You see what I'm saying? So I'm not producing sperms because, you know, my hormones are out of whack. I got to fix that. I'm producing sperm, but the sperm is defective. Then I look at zinc, coenzyme Q10, arginine, all those things that look at the sperm formation. For example, sperm is one of the only, I think it's the only cell that uses fructose as an energy source. I don't know if you guys knew that. It uses fructose for energy source. So I have to look at all that and then I make a decision. I have no uses even for men for fertility issues, but I use it for women a lot.
I was reading that there were benefits of progesterone for men for stuff like that, for TBIs and all this, exactly what you described, but they said, but at what cost to their hormone panel that they had?
Actually, you know what? I'm glad you said that, Danny. I do check the hormonal patterns after I start progesterone. Perfect. There's no changes. And actually, I want to bring something that you guys might not be aware about it. Most people think that your ovary is the one that produces most of the progesterone in your body. And that is not true at all. Okay. Progesterone is produced by the corpus luteum. Remember, when you go into ovulation, you let the egg out, the corpus luteum becomes the producer of progesterone. For postmenopausal, 80 to 90% is made by the adrenal glands. And progesterone is the hormone that goes before cortisol. So if we don't have enough production of progesterone, then we cannot make the cortisol to respond. So what I have seen on people with highly stress and anxiety, I see that the progesterone actually helps the cortisol levels to normalize, Stephen. And that's done with urine tests. I've done it with a urine test. Now, does it always work? No. In medicine, nothing works 100% of the time. But I've seen a massive difference with anxiety, alcoholism, with progesterone.
Okay. Next. Someone said, when should you schedule your medication to try to match circadian rhythm? I was always told that it doesn't really matter. They say you take your testosterone and your hormones in the morning to try to match as much as possible, but by the time it's actually metabolized, is there a way to take?
I'm going to disagree with you and agree with you, Danny. Okay, I haven't used testosterone, so I cannot say from personal experience, but I have people that have injected testosterone and they can sleep. Okay, the first 2 or 3 days, I injected testosterone, I can't sleep. Or I inject it in the morning and I can't sleep. Now, I want to give you an answer to this question that this person might not like. It depends. Are you flying? Are you stopping at your house? Do you have to do it in the morning because you're going to get up? Or what happens? You're a night shifter. I might want to use it at night to keep you maybe better concentrated at night because I want to get you levels because you work. You're going to be stressed. You're a fireman. You're a policeman. You're a nurse. You're a doctor that is staying up at night. I might want to give it to you at night. You see what I'm saying? Because I'm trying to imitate what you're doing. Now, would I do it in the mornings too? Yeah, I might do it in the mornings, but that depends on each patient. Now, it depends on the amount of stress, depends what I'm doing it for. And I don't do this anymore, guys. If I was going to do performance, and I don't know what performance is anymore, I might make a person take testosterone sublingual an hour before a game or whatever. You're going to jump high, because it will get you levels higher before that activity. So I can manipulate that also that way. Now, is this the best time? No, it's the best time that the patient can do it. That is the best answer for that. Now, if you're a night shifter, I will manipulate those hormones so they help you for your night shift work.
Okay. Someone asked if a high testosterone reading in the blood from TRT can cause a low cortisol blood reading. Someone had got implanted pellets because of poor absorption issues due to scleroderma skin. He's unable to use cream, so there was a pellet implant, and cortisol was normal before, but then it got really low. Can that be because of the TRT, Eric?
Yeah.
This is a woman. Sorry, no, this is a woman who posted, but it's for her son. Sorry, I take it back.
Okay. No, that's okay.
Yeah,
okay. Let me talk about females. Oof. This is tough. Okay, if you look at a chart and you say, okay, I'm going to look at hormones, right? And men use sex to relieve stress. Women use sex to relieve our stress, but they don't get relief stress with sex, okay? Now, when a woman stress, okay, they tend to go to cortisol because they're stressed. And that takes away from your testosterone, your adrenal glands. So will testosterone affect your cortisol levels? Absolutely. If you start using a lot of testosterone initially, your production of cortisol might actually go up because now your progesterone says, I have enough testosterone. I'm going to go into the cortisol cycle if I have enough stress. One, if it's chronically used, it might give you no more levels to low levels because now you have the testosterone. But when do you measure cortisol? I'm assuming she measured either urine or saliva. What's the person working out? What's the person having stress? What's the person waking up? Did the person have coffee the night before? I would have to ask all those questions to find out were the cortisol levels really what they were supposed to. If they did a urine, which is usually either a 5-spot urine or 24-hour urine, then I will get a better result. If I use a saliva, it's not as accurate when it comes to that. It just tell me if it's high or low. With the urine, I have a little better idea. Now, testosterone absolutely will affect your levels either in a man or a woman. So cortisol levels can either go up or down depending where you check this test. Now, if you do it 2 days after the testosterone levels, it might be high, it might be low. If you do it when it's chronically, they might be totally normal. So that depends on the patient also.
Okay, thanks.
You guys see the difference between Eric Serrano and most other doctors. Eric is going to want to know, how often do you take your dog to walk? What is the name of your dog?
Yes, absolutely.
Every single detail is going to grill you.
I
like
have to know. I have to know. And you also, even Danny, you also mentioned this is a woman asking for her son. This is kind of interesting. That means that the son is already worried because he's asking the mother, and the mother is trying to find out what is going on. So there's something already going wrong in this not between the relationship between the mother and the son, but something is wrong with the son. You see what I'm saying? Because the mother is the one.
Our son is not. He's a young guy, and the mother has bringing him to the doctor, and they're trying to figure it out together.
So do you see what I'm saying? There's a stress factor right there already. What's happening? The mother's stress is going to stress the child. For example, there's a study that was done. It was in metabolism. I don't know if I still have it, in which they were going to follow parents that were abused or mothers that were abused by the parents or by somebody, either physically, emotionally, or verbal. And they were going to follow the children to see what happens to the HPA axis. This woman were pregnant. The child wasn't even born yet. And they were going to follow until adulthood. They stopped at 12 years because the HPA axis of those children were still affected, even though they were never abused, which is crazy. So, there's so much things going on.
Got it.
Okay.
Stephen, was it me now or what?
Stephen.
Yeah, I asked about cortisol. Okay, problem. Next, Eric. Pregnenolone. What's the ideal blood range for optimization?
Stephen, you're breaking up. I didn't hear the question.
He was asking Pregnenolone. Pregnenolone, is there an optimal level of blood range?
Okay, Pregnenolone. I rarely measure it. Okay, well let me explain to you why, Stephen. It's not because I know it all. It's just because I measure it sometimes, and it might be low and the patient feels great, and it might be high and the patient feels like shit. So I said, what's the level giving me? Now, I have learned from Pregnenolone, actually from patients from England that fly to see me, and they are in Pregnenolone. Now, some of them use 5 milligrams, some use 50, 100. Pregnenolone doesn't do nothing. As far as low dosages, I never see any huge findings with it. With the high dosages, I see something happening. I see a little calming effect. I see more relaxation. I see, I feel a little better, but also the extreme. I've seen severe depression with Pregnenolone. I mean, I do not know the mechanism of that, but I have seen both sides. Now, most of the Pregnenolone used in my office has been provided by another physician, had never been prescribed by me, because I don't see the results that I would like to see. Now, remember that Pregnenolone is the first or the limited factor from cholesterol to Pregnenolone by the start, okay? And I mean, if we say, oh, I give you Pregnenolone, well, why in the hell I don't give you cholesterol? You see what I'm saying?
Mm-hmm.
But that is the first step that actually is the limiting step. So doing Pregnenolone can go down the cascade and activate everything else. Well, I have seen people taking 50 to 100 milligrams of Pregnenolone, but I have not seen the response down the cascade as I expected. So Pregnenolone is also considered a neurotransmitter, so affects the brain more than the rest. I don't have the answer to that because I don't use it. I do not know the answer to that one.
Okay. Can we use DHEA and Pregnenolone in cream form for people who cannot tolerate the oral forms? Does it give the same benefits?
Okay. Wow. I had never seen a person that cannot tolerate DHEA except females, because they can get a lot of conversion to testosterone. They might get the hair and the pimples and stuff like that. That means we're giving them too much. Cream DHEA, I also seen it. Sublingual DHEA, I've seen it work for erectile dysfunction, believe it or not. On the cream, because again, Stephen, I don't use Pregnenolone cream. I don't have the answer to that one. I do not know. Now, is DHEA absorbed through the skin? Yes, it is.
So let's say a guy that takes, I'll give you 2 examples.
What?
I take Pregnenolone and my libido tanks in 3 days.
Yeah, that's what you see.
Nichols
So people get better.
DHEA, and he breaks out in pimples. Even Neil apparently is the same thing. Neither of them can take DHEA. So I guess the question would be, if you're taking a transdermal form, would the absorption of it change the outcome, change the way they're reacting to it in a negative way?
Yes, Stephen. I want you to remember, Danny, as soon as you put on your skin, if it's going to be absorbed, like progesterone cream, I had never seen it really work. And there might be people say, oh, I use progesterone cream. Good for you. If I'm in the United States, I don't want to get sued. I'm going to use oral. Don't use freaking cream because you need to protect the woman's endometrium. And the only thing showing that protects endometrium is oral. I don't care what they tell you. Never use cream progesterone. Now, when I apply anything on my skin, anything, Danny, it's going to, one quote, they say it's going to bypass the liver. That means it's going to go into your veins and it's going to go all over your body and then eventually end up in the liver. So every drug that you get is going to end up in your liver. I don't care what they say. But on this case, it's going to bypass everything and go into your skin. And that's going to go into your blood vessels first. And it might get dumped. And DHEA might be giving you better results doing it that way. I get such good results oral that I'm not worried about. Now, DHEA for me works better when I use sustained release or sublingual. If you're going to buy DHEA over the counter, don't. We checked, and I did this about, I would say 12, 14 years ago. We look at DHEA, we look at products. We do 12 out of this. We went to stores, I don't want to say which stores, and we picked the DHEA. None of them had DHEA, none of them. Oh, I take it back. There was 2 with DHEA, but they were either, I remember it says 5 milligrams. They were like 20, 25 milligrams. And the other one says 50 milligrams, only have like 1 or 2 milligrams. So be aware of that when you're taking DHEA. Make sure that you buy it from a reputable source. 2 is, can you use DHEA cream-wise? Yes, you can use it, and it bypasses the liver. So you might get higher DHEA sulfate levels. Now, when a person has side effects from DHEA, as you were mentioning, I will look at sulfation. And let me explain to you what that means in a second. There's 2 types of DHEA. DHEA sulfate and DHEA plain, okay? And the sulfate is a storage form of it. That means I have to have a sulfate source to be able to store it. Now, if my liver is not working correctly or perfectly, and my sulfation is limited, because sulfation, Stephen, is a detoxification in the phase 2. Remember, sulfation, methylation, conjugation, glucuronidation, all those things happen. If my DHEA cannot be sulfated, I might have issue with that DHEA. And I have to go look at something else besides that. I might have to look at glutathione levels. That means, you cannot metabolize DHEA like you're supposed to. I got to look at all those things before I make, oh yeah, that is what the reason why. And of course, you having side effects, stop it immediately, because we want to find out what you're doing and get levels. Now, I have seen levels in my office of DHEA 500, 800, and the patient has no complaints.
Okay.
Danny?
Me? Get back to my list. Someone posted, it would be interesting to hear his take on growth hormone importance. Many on TRT seem to have low-ish numbers on IGF-1. What are the benefits on supplementing for well-being and longevity? And his opinion on peptides like sermorelin, ipamorelin for the purpose. If this is something you wish to answer, Eric, go ahead. If not, we can skip to this one because I know you're iffy on the peptide stuff.
Okay, how do we do this? Okay, this all I'm gonna say. First question, do peptides work? Absolutely. I cannot deny that peptides works. Peptides are sure. Okay, let me explain this a little bit more. If I inject growth hormone, right, we know that the growth hormone that I'm injecting in my body is going to become 22 different peptides. We know that by blood tests. Now, we know of those peptides what 3 do. One makes you help you get lean, the other helps you tendons and ligaments and your joints, okay? We know that. Now, does testosterone works? Yes. Does ipamorelin work? Yes. Do they work like growth hormone? No, but they do work very well. I don't prescribe any peptides in my office. Now, if you ask me about which specific one, because you mentioned two, testosterone and ipamorelin, I'm assuming that you want to use those for increasing growth hormone or no growth hormone or IGF-1 levels. Yes. Now, is growth hormone significant for you to help you be healthy? Yes and no. Yes, if I have joint issues, I have seen growth hormone work like magic, especially with osteoarthritis and joints. It just works like magic, okay? Tendons and ligaments, I've seen it work like magic. Now, growth hormone is a glucogenic drug, meaning if I inject DH on you, it's going to elevate your glucose. Now, if you are stupid and you're eating lots of carbs, you can get what is called a increase on those glucose after eating, maybe, and you're going to get a glycomark and a glycomark is a marker for sugars after a period of eating, and it's going to come down, which indicates that your sugars are going up and down, which is worse than just having high sugars all the time. Now, longevity. Okay, I don't give a shit which doctor, I don't care. Me and Neil, we can look it out. There's no longevity trials because this baby boomer generation is the ones that are using growth hormone. Not the old people, us right now, and there's no long-term data on longevity because we have not lived long enough to prove that growth hormone really helps us live longer, okay? I don't care who tells you, oh, increases longevity. There's a recent paper that showed that increases the thymus size. I don't know if you saw, I sent it to you guys, in which they use DH, zinc, metformin, and DHEA. I cannot remember. They use 4 things. And that increases the thymus size, meaning what makes you T cells. That's what the T cell comes from, the name. And that makes that you're supposedly getting younger. Now, when you inject GH doesn't work directly in your body. The GH goes into your liver, and the liver makes you make insulin growth factor 1 and 2 and 3. Now, there's insulin growth factor binding proteins. And when you inject GH, also your liver will make those to protect yourself against other issues because it's binding that growth factor. Now, cancer cells had markers for IGF-1. And in mice, which they're not humans, injecting IGF-1 can increase the size of cancer. Now, there's a conditioning in South America in which these people are dwarf and they live a long time, okay? And these people lack the GH receptor gene, or they don't have it, and they live longer, but they're very short. Okay, do I want to be short and live longer? I guess depends where I live, okay? Does GH increases your lifespan? Absolutely bullshit. You cannot say that yet. Can I make you feel better? Yes. If you have joint issues, yes. If you have tendons that are hurting, yes. It will help you versus an injury, yes. Will it help you live longer? I don't have the answer to that yet. Can it increase performance? Absolutely. Can it help you? Can it get you leaner, which will allow you to live longer because you have less fat? Maybe, or I don't have the answer to that. Okay. Steven.
Okay. Very clear. A question related to that. What are the optimal IGF-1 ranges in men over 40?
Okay, optimal. I love that question. See, what are my optimal? Okay, I hate people. You know, that's why I like dogs and goats and stuff like that. Okay, I don't give a shit who you are. I don't care. And I see sometimes I told Danny, don't get involved with people that only use labs to treat a patient. Now, Stephen, you're a physician. How often have you only used labs to treat a patient in your practice? Never. You can't. I have seen people with testosterone level 200 that can come in and squat 600 pounds. You know, I'm thinking, shit, you know, what's going on? So what are the optimal levels? Optimal levels are where you feel the best. So you might be 10. The next guy might be, okay, my wife just showed me a case that the IGF-1 levels are 355, which is extremely high. For a woman, I think the upper limit is 154. Well, she's 355, but she's complaining of headaches. Now we have to go look at, okay, so she has a pituitary tumor because the IGF-1s are so high. You know what I'm saying? So does high means better? Absolutely not. Now, remember what I just told you, cancer cells have IGF-1 receptors. Is too high good? Is too low good? There's a guy named GOD, right? So GOD is right here, and MD is really right here, very low in the corner. Then DOs, then computer programmers like Danny are way below those people, you know. And then you know, but you know, people are so stupid. You cannot get based in one lab. IGF-1. Well, what are your testosterone levels? What are your thyroid levels? What are your estrogen levels? What are your progesterone levels? We need to look at the whole picture. Okay, for example, I want to increase my IGF-1 levels. What is the best way to increase IGF-1 levels? Easy answer. I know you're going to think about this. Fasting. Fasting will increase your growth hormone, will increase IGF-1. So I can get IGF-1 level on you this morning and you fasted for 48 hours because, hey, you know, I need to fast, I need to lose weight, and I get high IGF-1 levels. For example, on wrestlers, I get IGF-1 levels high usually. And I go, what? Why do you think I get high levels? Because they want to lose the weight. Oh shit, I got to wrestle tomorrow. I got to lose 15 pounds. And they don't eat, they only drink water. So the IGF lowers go up. So what is optimal? I have no idea. It's how do you feel, first of all.
Exactly.
Okay.
Okay.
Danny?
I don't like you either, Eric. Does TRT affect any other minerals absorption beside iron, sodium, and calcium?
Yes. Yes. Okay, that's an interesting question. Is that for a man or a woman?
Man.
Man. It's kind of funny that he says, well, TRT affects sodium, calcium, you know, yes, affects. It is affects. Okay. If you are absorbing calcium, okay, then you're gonna affect something else, magnesium levels. Got it? Because calcium goes up because you do have an increased calcium, but magnesium actually increases also, believe it or not. So testosterone affects so many other things. For example, testosterone might help your thyroid work better. Your testosterone might also help your parathyroid work better. So everything, you cannot isolate one value. Now, testosterone also affects boron levels. Okay, people are not aware of that. Boron affects free testosterone, but testosterone affects boron levels also. So they go back and forth. Now, I have a great paper that has how one electrolyte or mineral affects another one. For example, lithium. Lithium is affected by testosterone levels. And you guys are going to go, what? Who the hell said that? Okay, people think that lithium is not necessary for life. Now we know that lithium actually is a mineral that is essential, especially for people that also have neurogenesis, especially for people with traumatic brain injuries. You want to put those people on lithium. Now, do you guys know that I can have a red blood cell that is very large, okay, or it's called megaloblastic anemia, in which the cell is really big, and I can have all this B12, and the B12 is floating around, or it doesn't get into the cell. That's because the red blood cell has a lithium B12 pump, meaning I require a certain amount of lithium to punch in my B12 into my red blood cell. And also when I increase my testosterone level, my red blood cell production goes up. That's what is called erythrocytosis and not cancer. It just increases your red blood cell formation, which requires iron, but also will require B12. Why? I'm making more red blood cells, correct? So I need more red blood cells to be normal size. Are they going to be big or small? If I don't have iron, they're going to have issues. If I don't have the B12, they can get too big. So absolutely, testosterone affects absorption of other elements of nutrients. Allows you to absorb more sodium? Yes. That's why the increase on blood pressure. Maybe, maybe not. So it depends. But let's suppose that you take testosterone or you're in a low salt diet. What's that going to do to you? Does testosterone affect cholesterol? Okay. This is another one. I got people that the cholesterol is 300, 320. Of course, they went to another doctor. Oh, you got to start statins. Well, I check his testosterone levels. They're 100. I said, well, dude, you're making cholesterol because your body's telling you you need freaking testosterone. I put the person on testosterone, you see the cholesterol go down to normal immediately. But we cannot think past that. You have high cholesterol. Oh, what happened? Your vitamin D is 10 or like 2 that I found in my office. Well, your body's making cholesterol because it requires vitamin D. Well, I need to make cholesterol to make vitamin D. But people, they can't think straight about this. But yes, testosterone affects a more large amount of electrolyte than just calcium, affects magnesium, affects boron, affects iron directly. Believe it or not, affects chromium. Zinc is affected either by testosterone or not testosterone. So all those things have to be looked up into if you have a condition. So that's why I said, do not look at a lab, look at everything together and then put it together.
Eric,
Okay.
based on what you just said, are you implying that people that are on TRT that are getting erythrocytosis to whatever extent, would they benefit from B12 supplementation?
Yeah, sometimes they do. Absolutely. Okay, let me explain to you. I have a case that the guy had no more levels. He was put on testosterone by somebody else. Come to see me because he had, and I don't know how they work in Canada or in Belgium. Do you guys measure MCV, Steve? Mean corpuscular volume?
Yes.
Okay. Okay, that is when that, Danny, that tells you is the cell is too big or too small, right?
Yes.
Okay, so I put you on testosterone, you increase erythrocytosis, which was normal before, now have an increase. This person has no more iron levels, or his cells, he was making more red blood cells, but they were big. The MCV was 102, which actually now said, hey, I had a B12 deficiency. I didn't know, but it was manifested because because he was placed on testosterone. Now he had no mesanthigmins in the hand. He was tired. The testosterone made it worse. But it wasn't that the testosterone made it worse. It's because the testosterone induced erythrocytosis and the B12 level went low. Once I put on B12, the cells went back to normal and he was fine. So yes to your answer, Danny. Got it?
Got it.
Okay.
Steven, you go.
Next question. What can men on testosterone optimization therapy with the COMT genetic mutation do or take to keep things running smoothly? That's the catechol-O-methyltransferase gene.
Oh, I know what that is. I'm very familiar. I love that gene. Okay, let me explain what, for people that are listening and don't know what catecholamyl COMT, catecholamyl methyltransferase. So for people that don't know that, it's just, I have, hold on a second. I have a molecule that has 3 hydrogens, and these 3 are 3 hydrogens. And I'm going to donate these 3 hydrogens with the carbon to another molecule. That's methylation. Okay. COMT are necessary to make hormones. They're necessary to clean hormones. They're necessary to clean neurotransmitters. Also, when the catecholamyl methyltransferase is not working, then you're going to have issues. Now, for that enzyme to work, you require folate, folic acid, you require B12, or you require SAMe, S-adenosine methionine, which is the main methyl donator in your body, but also requires choline. So eggs, things like that, or TMG, trimethylglycine. Okay, so let's suppose that you have COMT and now you started testosterone, which might make your norepinephrine go up because you're going to be hunting now for women. Okay, you're going to get more stress. Or you were fat and you started testosterone, and okay, and here we go, me and Neil, we're going to duke it out. If you're a fat ass, okay, that doesn't do nothing, and you sit on the chair, and I put you on testosterone, what happened to you? All of a sudden, woo, I want to go outside and exercise. Well, you had a heart, you know that testosterone costed, the testosterone made you better enough to get your ass out there and then have the heart attack because now you're exercising, you know. But catecholamyl methyltransferase is necessary for the body to just do cleaning, to make other hormones. So if I have a person that has COMT mutation, depending on which one, there's 2 mutations. There's one, 5-6A, I think, that decreases activity, and there's another one that has increased activity. So for example, if I have somebody that have increased activity, you might have lower dopamine levels, which will make you depressed. Got it? So that person, I don't want to give him SAMe, I might want to give him B12 folate. Okay. Another person might say, I'm not methylating enough. I might want to give him SAMe. I might want to add choline. I might add glycine to that person, and that will help repair that issue.
Eric, we had a discussion once about oral B12 and injectables, and you said they're pretty much the same thing, right? Because I know now, yes, based on what you're saying, everyone's going to say, oh, I got to take B12, I got to take B12.
No. It's not the same. Doctors are cheap. I'm cheap, right? And in my office, I use cyanocobalamin, which is a red solution. And I inject that because it's very cheap to do that. Now, that is not the active form. There are 13 different types of B12. Nobody knows them. I mean, there's many, okay? There's S-adenosine methionine. So, for example, if you have a MUT mutation, you need S-adenosine methionine. Cyanocobalamin will not work. Let me repeat that. If you have an MUT mutation, you need S-adenosylcobalamin. Now, the most common one is methylcobalamin. Now, people have no idea how B12 works. And guys, I'm sending you a paper that you guys are going to love, okay? The cobalamin is just the carrier for whatever molecule we're using. Got it? It is not what you think. Oh, it's B12. No, the cobalamin is just a carrier. The rest of the molecules what matters, okay? Now, the question is B12 oral the same as injectable? No. If you have a person that has what is called intrinsic factor deficiency, and that is a small protein that is made in your stomach, Stephen, which will carry, it's the taxi to get the passenger, the B12, bring it to the ileum, and at the ileum you absorb. That's one. Two, if you have Crohn's, ulcerative colitis, you had a blockage and they remove part of your intestines, that person will have issues absorbing that B12. So I'm going to use injectable. Or you can use sublingual. Now, there's something called transcobalamin. That's another, is inside your saliva. Transcobalamin, when you chew your meat, I'm eating it, the acid will break down the B12. Well, transcobalamin grabs the B12 and protects it until it gets into the stomach, which will be destroyed there, but transcobalamin protects it. And then the intrinsic factor, you go down the intestine and the intrinsic factor has it. So no, it depends on the person again. As physicians, it depends. So you have a person that has Crohn's, colitis, intestinal issues, IBS, they might not absorb the oral, I will go sublingual. Now, if you have a person that requires shots, yes, I will use shots. Now, my preferred shot will methylcobalamin, but it's very, very expensive. So I will use the cheap one, cyanocobalamin, because the body will take the methyl and give it to the B12, but then you have to spend a methylation. So it depends on the person. Now, shots work better for older people because they don't tend to eat. They have difficulty swallowing. So don't compartmentalize yourself, Danny. Think open. Okay. Yes, it's good for some situations. No, it's not good for other situations.
Okay.
Okay. Stephen.
I know we only got a couple minutes left, so I'm going to go through the ones that I know a lot of people were asking. Is low SHBG, and when I say low, I mean in the single digits low, is low levels like that, are they really a problem when on TRT? And if so, is there any way to raise it, or should we be raising it?
Wow, I love this question. Is SHBG really low? You're in deep shit. The only time that I've seen very, very low SHBG, you're almost always either too much carbohydrate or high levels of insulin. So SHBG is an indicator for high level of insulin or high carbohydrate diet or a very, very low glycomark. So actually, in some people, I might do an SHBG. I rarely do it, but I will do it as a marker for showing, hey, listen, this is very low. Be aware. This is a risk factor for you. So is SHBG low bad? Yes. Now, can testosterone lower SHBG? A little bit, yes. But the worst is carbohydrates and insulin. So make sure that you be aware of that. There are some drugs that lower SHBG, of course, and there are some drugs that increase SHBG. Now, you do not want to increase SHBG due to drugs. For example, birth control pills increase SHBG, but you don't want that increase. Okay, so if you have very, very low levels of SHBG, make sure that you're not obese, make sure that you're not eating carbs all the time, make sure that insulin levels are normal.
Okay, so nobody should be trying to modify those values using any type of supplementation drugs.
You know, boron lowers SHBG. They don't know that, but you know that. Boron thyroid lowers SHBG, but that doesn't mean that you want to do that. I mean, it's kind of funny. I mean, why would I want to lower a drug that is there to actually protect? Now, they do not know this. Danny, I'm going to teach you this. Does SHBG help your lungs? I'm going to ask you this question. Stephen, does SHBG help your heart? And the answer is yes. Yes, they are receptors. Let me repeat this. And I know, Scotty, I hope you're listening, Scotty, because Scotty will send you 20 papers. There's SHBG receptors in the heart and SHBG receptors in the lungs. They bind that SHBG, and it goes and helps your heart beat better, and it helps you breathe better. Do you want to lower SHBG? I wouldn't.
The reason a lot of people are trying to want to lower it, what I'm finding is the doctors don't want to prescribe enough tests. So let's say, for example, you got a guy who's got SHBG, you know, it's 65.
Okay.
And the doctor's only giving so much test. And he's like, well, I can't get my free T up because my SHBG is up. So maybe if I brought my SHBG down, I'll have more free test. And that's the mentality. And I keep looking at them. I'm like, you just don't want to do it. You need more free T. You got to get more tests. If your doctor doesn't want to give you more tests,
you know, Danny, I'm going to give you a way to explain it to them. Okay. I have 12 cars parked on my fucking drive. Okay. I got 12 cars parked there. But I only have 3 keys, right? 3 keys. But the 3 keys are for the first 3 cars parked on the front. Okay? You need more keys. You don't need to, you cannot remove those cars. So you need to get the keys to remove those cars. So I agree with you, Danny. You require those free testosterone. Give yourself more. Let's get the keys to all the other cars so you can move those cars out of the way. Got it? So you're correct.
Exactly.
Yes, SHBG, don't lower it. Go ahead and freak. And you want to lower it, eat sugar. If you want to do that. And that might increase your testosterone levels, yes, but not the right way. You see what I'm saying? No, don't do that. Just tell the patient, tell the doctor, or you can do this. You can tell the person, listen, tell that patient to trick the doctor, and this is going to sound bad. I rarely give this advice. Tell him to go 10 days low carb. SHBG will drop, but also because he's eating lower caloric intake, his testosterone levels will be low. So he goes to that doctor and he goes, let me check now they're normal, but my free testosterone are still low. What are you going to do, doc? And the doctor's going to go, oh shit, I had to give you more testosterone. Got it? Don't tell them that I said that. Just provide that.
Got it. Will do.
Got it?
Before we went live, Eric, you were talking about the bodybuilders using all these different kind of compounds. A lot of them are using proviron as well to lower this SHBG. So why?
Yes. Okay. When you're taking many cocktails of drugs, Stephen, if you're taking one, it's okay, but average amateur bodybuilder takes 4 drugs. Okay, it doesn't matter what they are, but they do. And when you're taking many drugs, okay, their hormone derivatives will actually increase. They will do something to your SHBG. Okay, it will also do something to your estrogen levels, which estrogen levels actually increases SHBG, right? Estrogen increases thyroid binding globulin. Estrogen increases zero hormone binding globulin. Is that the reason why estrogen saved your life? I mean, I don't know. I'm just being fictitious. That might be a way that estrogen helps you, right? Now, before I continue this, Danny, are you familiar with proviron? You know what that is? Proviron?
Yeah, a little bit. I've never taken it, but I know why some men are taking it.
Yeah, it's anabolic steroid. They say it's like a progesterone derivative, basically, and it's supposed to help you with that. It makes you harder. That's what they say. Now, is it making you harder because it controls actually estrogen, or is it because it's affecting the SHBG? The amount of hormones that they're taking, I don't think that is the real reason. Most of the people that I see taking on my office are at the end of the cycle when they say I gotta stay hard or be very lean. That's when they use it. But otherwise, is it wise to use it to lower SHBG? No. Freaking, if you're going to lower your SHBG, supposedly it's really affecting you, that means that you need to play with your cycling of carbohydrates. When are you carbo loading? When you're not carbo loading? When are you fat loading? You know, depends on that person, what they're doing with it.
Okay. Danny, you pick a few more questions from the list you have, but other questions came in the chat box, and I promised some guys that I would ask them. I will take from the chat box, Eric. Someone said he has cysts on the kidney. Someone said he had cysts on the kidneys, and he asked, will TRT have any effect on those cysts? They were found 15 years ago by checking for stomach problems.
Okay, Danny, I didn't hear the question because it was breaking up. What was the question?
Stephen, you're breaking up a lot today for some reason.
Well, I didn't hear the Stephen. Well, Stephen, I didn't hear the question. I'm sorry. Can you repeat it, please?
Someone has cysts on the kidneys.
Okay.
Just randomly discovered by checking for stomach problems. Will TRT affect those?
Okay, that's a great question.
Okay.
Because the technology now, we tend to do more ultrasounds. Usually it's that's how they found it, I'm almost sure. A lot of people have cysts. 90% of those cysts are usually benign. Testosterone does not increase those cysts, okay? I had never seen it done it. I had seen by accidental that the person who has never taken testosterone had 1 or 2 cysts, and all of a sudden comes back, yeah, I have 4 cysts. My doctor told me to stop it now because the testosterone made it worse. I have 3 cases in which that happened in my office, that where they came to see me, not because I prescribed the testosterone, but because I only have 2 cysts. I started testosterone, now I have 4, right? And then when you look at the history, you look at the parents, your parent have, cysts. Now you can have polycystic kidney disease, in which the kidneys are full of cysts. That's like Dan Duchenne. But no, testosterone should not increase cysts unless, Stephen, you have what is called blood cysts, in which you have cysts that are full of blood. If your red blood cells go up, maybe you might make it worse, but that's a speculating, not true statement. Okay.
Eric, quick question.
Yeah.
There's a guy who works as a nurse. He is anti-vax. He never wanted to take vaccines. He was obligated to take a vaccine. Okay. Now he wants to detox. What is the best way in your opinion, for someone who wants to detox from the mercury?
First of all, anybody that's going to get injections should get vitamin A, C, and E. Okay. Now, when you take vitamin E, it's not the delta or the alpha, it's the gamma. Okay. You have to take all the tocopherols and trocotrienols. So when you go vitamin E, you need to have all of them. Vitamin C, you need 2 grams. Vitamin A, you need between 10,000 to 50,000 of IUs of vitamin A. And when I say vitamin A, I mean retinoic palmitoic acid. Okay. And there's a supplement that is called liver detox that works amazing. And it has NAC, it has alpha lipoic acid. You have other things to help you detoxify that drug. But one thing that people do not know, believe it or not, I don't know, Stephen, this was before your time. Have you ever heard liver capsules or dehydrated liver? Okay. The bodybuilders in the old days, they used to take liver and dehydrate it and eat it or cook it on capsules. And actually, desiccated liver. Take a bunch of those because it helps your liver get rid of stuff. Easy, cheap. If they want a phone number, hold on a second. Let me give you a phone number right now.
I used to take that when I was about 14 or 15 years old, when I was reading the muscle magazines and stuff and training in my friend's garage, and we would go buy desiccated liver at the pharmacy.
I love it. It's one of my favorite supplements. I use that with almost everybody. When I was competing, I would take between 50 to 60 capsules a day of that, and I eat liver. I made my wife make liver all the time. People say, ooh, liver, it tastes, my wife does an awesome job. But okay, the phone number is 401-885-4070. You can ask for liver detox. You can ask for the liver capsule. They have it. That company is pretty good. So I would highly recommend for that guy, ACE, ACNE, the levels I told you, and the liver desiccated liver.
Okay. One more question from my side here. Why do bodybuilders using different anabolic compounds do cycles in what they call blast and cruise? Why don't they stay on high doses for years on end? Because we talked with Scott Howell about receptor upregulation, downregulation. There's no receptor saturation. So what's the real reason not to stay on high doses?
Because they stop working and it costs money. Okay, let's suppose this is an easy answer for them to understand. When you start testosterone, initially it works very well, right? Now there's people out there, I'm going to take more testosterone or I'm going to add something else to work. So when you start being a bodybuilder, the first drug helps you, then the second drug helps you, and the third drug helps you. Yes, one might help you gain more muscle, the other one might make you with your tendons, the third one might help you get dry, right? But then the fourth one is because you have side effects. I get bitch tits, I need to take a tamoxifen. Then, because the tamoxifen lowers my estrogen, I'm having joint pain, so I have to add ibuprofen. So after 3 drugs, you usually get side effects. The reason bodybuilders cannot stay on their cycle all the time, economics. They cannot keep spending that money. 2, they don't feel good. In 31 years of practice, Stephen, I cannot tell you I have met a bodybuilder that feels 100% good all the time. I have never met one. Okay, even including John. John is gonna kill me. John Meadows. You know, they will have some issue. You gotta come off. These people are not using physiological levels for their hormones. They're using extra levels, which will create side effects. 99% of the male bodybuilders that I see, all of them snore. They have sleep apnea. It's not because of testosterone, because they're taking so much. So some of them I need to back off so I can breathe better. Sometimes they retain fluid because they're taking so many drugs. I got huge and massive. I went to the show. I show myself. I need to wean myself off. Okay. So they also cycle because they're going to do a show. I'm going to use so much, and then I come off. Then I got to gain mass. I'm going to get mass. Now, power lifter, use it for a different reason. Cycle. Okay. So here are bodybuilders. Here are power lifters. Power lifters do it for only one reason. I want to be strong. I want to kick everybody's ass. I'm not going to cycle because if I cycle, what happens to my strength? Goes down. So they have 2 drugs they always use, and they might have a 3rd or 4th one to get better. But otherwise, they don't cycle it. Now, power lifters, oh my God, do I have power lifters? I have tons of power lifters. Do they come off? No, they never come off. But now they do have high blood pressure issues. They have other issues they have to watch out for, but they don't cycle it. Now, they're not taking 5 drugs, 6 drugs. You see what I'm saying? But the first one is economics. Second one is side effects.
Okay. Maybe one more question, Danny.
Well, Danny?
Sure. This one might be easy. There's a bunch of guys in the group actually that have I don't even know how to pronounce the damn word. The varicocele cells.
Varicocele vessels?
Yeah.
Testicular?
Yes. Would that affect cream absorption?
No, it does not. It doesn't affect it.
Okay.
Varicocele veins, for you to explain, Stephen, okay, a vein looks like a tube, right? And that tube has valves on it, right? Okay, those valves open and close. Varicocele veins are just veins that the valve don't work as well. So the circulation is affected slightly. They have more blood usually because they cannot pump it back. So you have varicocele veins, you know what? Wear freaking tie undies. It will really help you. So apply it. Don't wear boxers. You have to be tie underwear like fruit of the loom.
I was going to say fruit of the loom.
Okay. I don't know, Stephen, what brand do you use in Belgium? Do they use fruit of the loom?
Stephen goes commando.
I know the brand. Yes, I use Diesel.
I had never seen those, you know, but I use whatever my mom bought me years ago. I still have some left. So, you know,
geez.
Whatever. I do have a lot of fruit of the loom. Right? But yes, that would help. Also, what is like on varicoceles? Temperature also affects the person. So on very hot areas, varicocele veins will get worse. With cold weather, it will make it better. So because it shrinks, actually, they do respond to that. So be aware of that. Okay.
Okay.
Eric, I sent you that T-shirt through Amazon. I'm going to send you some underwear also. Okay. Okay. Everybody, don't worry. He's going to get fresh, clean, brand new underwear. It's fine. Take care of it.
Show us the T-shirt, Eric. Show us the T-shirt.
I don't have it. Hold on. I'll be back. Hold on.
I sent them an extra large T-shirt, and it was too small. So now I have to send them an extra large. He's going to get it this week. And now I'm going to send them some underwears. I'll find some very special underwears for Dr. Serrano.
But this is my best set of underwear. Batman, you see that? And then, I don't know what the T-shirt is, but I'll find it. I'll wear it the next time. I promise.
Wear it the next time.
Okay.
Anything in the chat box, Stephen, that we need to address, or are we good?
I think we addressed most of it. Yeah, I saw. a lot of things pass. Okay, but I think we're 1 hour and 10 minutes in, so I guess we have to call it a day here. So thank you so much, Eric, for your
Steven.
time.
Thank you, sir. Thank you, Danny.
Thanks,
Thank
Eric.
you for co-hosting and arranging the questions. So thank you so much for watching, everyone. Leave us a thumbs up and talk to you next time, guys. Bye-bye.
All right. Ciao, guys.